I will hand it off to Dr. Peloso. Thank you so much for joining us today.
I appreciate the invite a great deal, Michelle. And I'm also grateful to a number of you online who are joining me I'm sure, at the end of a long day. And I hope you'll find this interesting and entertaining. At the very end, you'll see an email if you have more questions and a QR code as well. It worked for me when I tried it. I hope it works for you. That's another way you could reach out to us after this. I want to tell you about the company COUR. I want to tell you about our technology. I'm going to show you a couple of examples of how it's already worked for patients in other diseases. Then I'm going to talk a little bit about myasthenia gravis. Many of the information around myasthenia, I expect folks who are attending today will already know. But I will finish sort of talking about a study we're doing in myasthenia gravis, and invite you or your friends or family to participate. And as I mentioned, at the end, you'll see a place where you can reach out as well. As I mentioned, COUR is an abbreviation of the word courage. That's where the name comes from, and you see our mission statement there is to empower those with autoimmune diseases with safer, potentially curative therapies. We think we have one of those. It's very safe already in 100 patients treated. Haven't seen anything special at all. And we are seeing evidence that we're reprogramming the immune system, which is exciting for people with autoimmune diseases. We have a very experienced leadership team. Danielle Apollons, who has been with the company a couple of years and became our Chief Executive Officer in September. Myself, I've been in the clinic for 15 years and then in the pharmaceutical business for 20 years developing new drugs. And as mentioned, a very experienced team. And I am looking forward to helping COUR bring new therapies to patients. We have a number of ongoing programs. Of course, today we're talking about myasthenia gravis, but we are looking at type 1 diabetes. That study is going to begin in 2025, early in 25. Type 1 diabetes, the kind that kids mostly get, is an autoimmune disease as well. We have other things that are under development that we're not quite ready to share with the general public, but we also have some partnerships as well. Takeda is taking forward a program in celiac disease. I'm going to show you a bit of data. Primary biliary cholangitis, I'm going to show you a little bit of that data as well, showing you that it works. And we recently announced a deal with Genentech, and we're working with them as well. So it's exciting to have big pharma. We are around 70 people in our company, all experienced but small, but it's exciting to have big pharma companies also interested in the technology. I'm going to tell you a little bit about what we call the nanoparticle. You see on the right this sphere, and it has some key characteristics. It's around 500 nanometers in size, and it's negatively charged. And you can see, the negative signs all around the outside. And it's a polymer that is easily broken down in the body. It's broken down actually within minutes of getting into the immune system. Inside these polymers, we can put specific proteins, and the size of the overall molecule, the nanoparticle at 500 micrometers, and the negative charge means it's taken up by the immune system exactly the way that normal cell breakdown happens. You can imagine our cells break down. We have to have a mechanism in the body to clear the junk out, but we also have to tell the body, hey, this is our own cells. These are normal. It's not some bacteria or some virus. Don't treat it as some foreign substance. And so we take advantage of that normal pathway that's happening all the time in all of us, based on the size and the negative charge of the molecules. And what happens is these molecules go to the liver and spleen. Within 6 hours, they're almost entirely taken up by the liver and spleen. That exterior coating breaks down. It's very easy to break down in the body. And then those proteins inside get presented by a special type of cell called the antigen presenting cell. It's part of the mechanism where the body recognizes itself. But what we're doing is we're saying, oh, you've mistakenly identified the protein to the acetylcholine receptor as foreign. It's not foreign. It's your body, folks with myasthenia, their body reacting to something that it shouldn't react to. We're presenting it back in the way the body normally sees its own tissue, itself, as self. And we're retraining the body using normal mechanisms to clear cellular debris. We're retraining the body to say, this is you, it's self. Don't react to it. And that's really the underlying basis of how we are able to retrain the immune system. I'm going to show you a couple of examples where we've already done it. And this is a busy slide, but you all probably know about celiac disease and gluten sensitivity and maybe know folks with it. Essentially, what we did in this study, we took people with known celiac disease who were sensitive to gluten. And we said, we want you to have had a biopsy that shows that you have celiac disease in the past. And we want you to eat a good diet for the prior 6 months. And then what we did is we gave half the group placebo, inactive compound that we can use for comparison purposes, and that protein that I described inside the nanoparticle, this time with basically gluten in it, gliadin, the main component of gluten that causes the reaction. So we had two groups, one who got placebo, one who got the nanoparticle with retraining with gluten in it. And then we said, okay, do a 2-week gluten challenge. And mostly these people, we knew if we gave them gluten again, they wouldn't like it. Their bodies would react. And what we were trying to see is if we prevented that with the nanoparticle. And I'm going to show you that here. And it's a bit sciencey, but I'm going to make it super simple. On the left, the first bar is baseline. So you see very low levels of interferon production. Interferon goes way up when we have an inflammation. And the placebo group is in that orange with the red dots. And you see how interferon goes way up in folks who received placebo and then got the gluten diet. In the blue, you see the baseline for us, and then after the diet, you see very little increase in gluten at all. No difference between the groups that received the nanoparticle, but a big difference in those who received placebo. In the middle two panels, we tracked two specific types of cells. The names don't matter, but the names are on the side for people who are super interested in this: CD4 positive, CD38 positive, alpha 4 beta 7 cells. think of it as advertising on NASCAR. It just tells you who basically owns the cell. And we looked at two different cell populations, and you see in the orange how the cells that receive placebo really ramped up. And those are the cells that go to the gut and cause and facilitate inflammation. And you see in the orange, in the second bar, it goes up. In the blue bars, there's very little change. And so the nanoparticle prevented those inflammatory cells from, to use the scientific phrase, trafficking to the gut. And on the right, this is the really interesting thing. We actually did biopsies in people after they received treatment. And you see, again in the orange, those who received placebo, their gut shrunk. Now, what do I mean by shrunk? Normally, the gut is full of little finger-like projections, and those finger-like projections are almost like coral, moving in the water, catching food as it goes by. Those fingers shrink in celiac disease, and in severe cases, it kind of looks like the inside of a PVC pipe when those fingers are completely gone. And so you see in the orange how the height of those fingers, villi we call them, has decreased, whereas in the blue, it's essentially unchanged. So we've shown inflammation, abnormal cell trafficking, and change on the biopsy that's prevented with the nanoparticle when we put in the key protein that leads to celiac disease. So we know the model works. And I will say, we showed this to a Harvard professor. We showed the biopsies to him. And he said, if I looked at these biopsies in people who received your drug and I didn't know they already had celiac disease, I wouldn't say they had celiac disease anymore. So very sort of profound. So that's one proof point that we know the technology works. This was the second study that we just completed, and we presented at the American Association of Liver Diseases. It's a randomized trial, so again, placebo with two different doses. And you see in the figure at the top, this is our standard. You get two doses. We call that a loading dose at baseline, so day 1 and day 8, so sort of 7 days apart, and then we follow people. And in this disease, what was very exciting is we looked at ultrasound of the liver, and we looked at measures of liver stiffness over time. In patients with primary biliary cholangitis, their liver scars, and we can measure that with this ultrasound. So here in black, you see the placebo group. It continued to worsen, just as we would predict. And you see in the blue bar here, in those on the active therapy, it actually stabilized, maybe you could say even improved. And this was rapid and exciting, and certainly is evidence that the drug works. For me, what was very exciting, this is a disease that leads to end-stage liver failure and cirrhosis in transplantation. And there are equations that you can use to predict what the future is for any given patient at 5 years. And in the black line here, this is the placebo group, and you can see how their prognosis or their outcome is getting worse. Their scores are getting worse over time. And you can see here in the blue, that is the active therapy, how we've sort of flattened that line, meaning, and maybe this is too strong a word and it's not the most scientific word, but we've bent the suggestion of future worsening of these patients based on use of the drug. So we have evidence it's worked now in two different conditions celiac, where you can give a challenge and really jack up the immune system, but also in primary biliary cholangitis, which is a chronic disease, also with an antibody that's driving a protein that's driving abnormalities, and we've been able to reverse things there. So we're very excited about myasthenia gravis because there's a well-known couple of antibodies that drive the disease. It is T-cell dependent, not that that matters for you all, but our technology really changes the profile of the T-cells. We know that there's a large unmet medical need. That's what I'm showing in the middle here. And again, I'm not teaching folks here anything, I'm sure, but corticosteroids or steroids or Z-Pak, or it goes by a variety of names, prednisone, are used to really dampen down the worst of the symptoms. But the drug itself has real complications. And so in order to avoid those complications, people have tried to use other therapies to lower the steroid dose and still get good efficacy. And thankfully, as shown on the far right, there's a lot of new things coming for myasthenia, and honestly, it's about time. Many of them also are agents that reduce steroid dose, which is wonderful. Improve symptoms short term, also wonderful, but come with some serious side effects. And so our hope is that we can provide a therapy that not only can be safely used, can be used safely chronically without any real infection risk, which is mostly what a lot of these drugs have. This diagram is just to remind folks here that it's an antibody to the acetylcholine receptor. So if you look at the figure on the left, there's this funny spaceship-looking thing. That's the end of the nerve. And those little blue dots are not aliens exiting the spacecraft. They're supposed to represent acetylcholine, which is a critical chemical to allow nerves and muscles to communicate and send signals to the muscle. And those little blue dots, the little bits of acetylcholine, interact with those funny orangey brownie shaped things that are acetylcholine receptors. In myasthenia, antibodies to these receptors do two things. One, they block acetylcholine from interacting properly. Two, they trigger the body to actually destroy the receptors. And so one of the reasons physostigmine works and related drugs is it says, okay, you've got less receptors, let's keep the acetylcholine around longer so that when it does find a receptor, it allows for some signaling. One of the things the corticosteroids, prednisone, et cetera, do is they stop the destruction of those receptors. And again, I'm sure a lot of you know this. It's a rare disease. That means there's less than 200,000 people in the United States affected by it. It tends to have two age peaks, young adults, if we can say 14 or 15 are young adults, and then those over 50. It typically starts in the eyes and with something called ptosis or droopy eye or diplopia or double vision, then progresses into the face and throat where people might have trouble swallowing, they might have trouble speaking. Dysarthria and dysphagia are the medical terms for that. And then over time, it progresses to the arms and legs. We know in severe cases, it may affect the diaphragm and actually affect breathing, and people may need ventilatory support for a period of time, and sometimes chronically, as those muscles are involved. It's typically worse with use, I'm sure, as you all know. And the early testing and the testing in the clinic is to work muscles until they get exhausted, and then they're no longer able to work. It's often a difficult or complicated disorder to manage because it's associated with a lot of other diseases as well. 15% have some other autoimmune disease, a tumor in the thymus, which is a gland that's involved in the immune system, thyroid disease, systemic lupus erythematosus, Sjogren's syndrome, rheumatoid arthritis, etc. So it's a difficult disease to diagnose. It can be difficult to manage the symptoms, and it can often be associated with other diseases as well. I've said this a little bit, but the anticholineesterases work by stopping the breakdown of um, acetylcholine. And so those little blue dots coming out of the nerve, that is to represent acetylcholine. And all these agents sort of prolong the effect. So they give acetylcholine more time to find a receptor they can work with. Many of the other drugs are used to dampen the immune system, corticosteroids, antimetabolites, and many of you will be familiar with azathioprine or methotrexate or mycophenolate, all agents that we've used to try to dampen the immune system, block these T cells, but also lower the dose of corticosteroids. People have used transplantation therapies in the past, tacrolimus and cyclosporin, not as commonly used now because, they have predictable adverse events. B-cell therapies and rituximab has been around for 20 years as sort of the classical one, although we've seen some new B-cell therapies that are being studied, and they look interesting as well. Complement's a funny little protein, and what it does, I showed you those receptors that kind of look like bell peppers in a way. Complement is part of what we call in medicine the butter that makes proteins and cells look more appetizing, that leads to their destruction. And so it's been found that you can block complement and also improve the symptoms of myasthenia. The bad thing is complement is that butter is key to making bacteria look more appetizing to the immune system too. So if you knock it out, you can get some serious infections. And for that reason, the FDA has said it has to be used by a special process called a REMS process, a risk evaluation and mitigation plan. And of course, we've seen new therapies very similar to IVIG, which remove antibodies from the system. And what they do is they remove all antibodies, but they also remove the bad antibodies. So the good side is they remove the bad antibodies. The bad side is you need those antibodies to fight off infections. And so that is one of the potential risks of those therapies as well. Mostly all of these things can lead to increased infection risk, but they certainly work. And this is some of the data from Vyvgart. And you see the myasthenia gravis activities of daily living. You see at the bottom right, myasthenia gravis quality of life. And you see in the blue line, that's the active, and in that pink line, that's placebo. So for about 4 weeks, you have very good effects, and then it starts to wear off. Part of the problem is we're still trying to figure out what's the right way to dose these therapies chronically, because there just isn't a lot of data yet. And there is concern that potentially repeated dosing and lower the antibodies could be harmful. We just don't completely know for these therapies. I told you we have 2 diseases where we know the drug has already worked, and specifically for myasthenia gravis, I'm showing you an experiment in mice. And on the left of that figure in the middle, those dots represent a mouse that's not affected. So that just tells you the variability in the muscle assessment in the mice. The next one over is basically placebo. So you induce myasthenia in the mouse, you give it placebo, you see that grip strength really goes down. And to the right, those are 2 doses of CNP 106, as we call it, the nanoparticle that contains portions of the protein of the acetylcholine receptor that we're trying to retrain the immune system is self. It's normal. Don't react to it. And so you see there, as we go from 0.5 to 1.5 milligram dosing in the mice, we get basically back to the healthy mice in terms of grip strength. They don't look different than the healthy mice. So we know the platform works from 2 different diseases. We know it works in mice who have the equivalent of myasthenia gravis. And what we're now doing is we're moving into an early study in myasthenia gravis. So we're looking for people who have an antibody to the acetylcholine receptor in this study. And one of the common questions I get is, would it work for people who had a different antibody, like MuSK? Yes, but we didn't put that in this time. We'll do that in the future. Would it work for people who don't have an antibody? I don't know is the honest answer. I presume there's something causing the myasthenia in those people, but our mechanism depends on giving that protein and retraining the body to not react to it. So at this time, I don't have any data that really informs on people who are so-called antibody negative. I'm going to show you a little bit about the trial design itself. And so we're looking at men and women aged 18 to 75. We're starting off with those with more severe involvement, so-called class 3 and 4. So they will have moderate involvement of the eyes, head, neck, arms, and legs. And after this first cohort 1, 150 milligrams, which I'm sure will be safe, but we're going to double check, we will expand it to include class 2 to 4. So similar areas of involvement, but milder disease. And you see we're going to have 4 patients on active and 2 on placebo. I always get the question, do you need placebo? It sure would be nice if we didn't have it. The short answer is I don't believe there are going to be important side effects from this, but the only way to really tell sometimes the difference between the disease and the drug is to have a few placebo patients. So we've tried to minimize it, but we do need a few. We're working with a data monitoring committee, a group of myasthenia experts, and after we dose the first couple of groups, we're going to have them make a recommendation around a future dose. Could be higher, could be something in between. And so in sum total, you see we'll have 18 plus 36, which is 54 patients overall. And we're going to measure a lot of things that you would expect. We're going to look at antibodies to acetylcholine receptor and see if that goes down over time. We think it might. We're going to look at functional status as defined by Myasthenia Gravis Foundation. We're going to measure medication and use over time. We've spent a lot of time saying, what medication should we allow? What medication should we not allow? For many of them, so long as the patient has been stable on them or they've been off for, let's say, 4 to 6 weeks, many of them will be okay. The one that is hard for us, and if you have questions, please reach out. The one that's hard for us is the FcRn receptors, because you saw how it comes down and comes back up. And it's just, those make it hard to determine if we're seeing an effect of the drug or if we're seeing an effect of those FcRNs. And we've debated over and over what to do about those. For right now, I think we're excluding them. In the future, maybe we won't, but that's, you know, a common question that we get. What should you expect if you come to a clinical visit? First of all, you'll be treated by an expert in the disease and their study staff. You'll likely get some blood drawn. As I mentioned, you know, we're looking at a number of things, including how the antibody changes over time. The study coordinator will ask you, what have you noticed since you've been on the drug? And they'll be listening for any positive effects or negative effects, and they'll be recording that. You will be seen by a study physician, and they will do an assessment of muscle function called the quantitative myasthenia gravis score. It's a standard way to assess muscle strength, and you know, that's something that can be done in all patients in the same way. And we'll also be looking at activities of daily living. That'll be a questionnaire that the patient fills out themselves, and questions related to quality of life. And I'm going to show you, this is what a study visit will look like. So you see, you'll have a screening period where they'll check some blood work and do all these evaluations, then dosing on day 1 and 8. A lot of those evaluations will be completed, and then some follow-up over time. And we will, and I said I would show you the types of things that the myasthenia gravis activities of daily living score collects. And I suspect for a lot of you, it'll be very familiar. So you'll be asked about talking. Is it normal, intermittently slurred, constantly slurred, difficult to speak? And that's something you'll essentially circle. Chewing, is it affected? Swallowing, is it affected? Breathing, is it affected? Ability to brush teeth or comb hair, get up out of a chair, double vision, or drooping. So again, things that I'm sure people are very familiar with in their regular experience with myasthenia. And this is an example of a standard questionnaire that the patient would complete that looks at quality of life. And I'll give you a chance to read some of the questions as well. I'm frustrated by my myasthenia. I have trouble with my eyes because of myasthenia, trouble eating, limited social activity, affects my ability to enjoy hobbies, trouble making plans, bothered by limitations, trouble speaking, etc. And so this is a standard assessment of myasthenia that the FDA understands well and the study sites understand well. And it's a method for us to really determine if and how the drug is working. And so we have a number of sites open. We're actively opening the study as we speak. We have a number of sites in the Midwest open now, and you see those in Flint and in Michigan. We have sites in other locations in the U.S. We're continuing to open sites. I know many people in the Midwest might travel to get out of the winter weather. And so I'm showing, sites in locations that we know people often go, including Florida and California and Texas. But we're continuing to open sites, and we will help support you get to a research site if that's something you're willing to do as well. And I mentioned this is where you can email us at clinicaltrials@courpharma.com. And that's something that comes to me and Vanu, who's on from our team. And you can also scan the QR code. It worked for me. I hope it works for you, but that will take you also to the clinical trial site for COUR Pharma. And so I'm sort of going to finish here and remind you of a couple of things. We're just using the body's standard way of clearing debris and saying this is self. It's not some foreign agent. And we're just taking advantage of that and retraining the body that what it thinks it should be reacting to, it shouldn't. We've already shown it works in 2 diseases. We've shown it works in mice with myasthenia. And I didn't say much about this, but we've had very, very minimal side effects. Most of the things we've seen have been around those 2 doses, those intravenous doses, and then nothing. And they're not bothersome or serious things. They are just things that happen when you're in the office getting an intravenous. And apart from that, people have been well for months on therapy. And so I hope that you've learned a little bit about us. We're based in the Chicago area. I hope that you've heard a bit about our technology as well. But mostly, I hope all of you best luck and success in your myasthenia journey for you or your family or whoever's affected. And I'm just grateful as a physician that we have so many more options, I must say, than when I went through my training.